Hello and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Over the Ethical Rainbow, providing services and support for LGBTQ populations. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program and then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, continuing education credit will only be awarded for 1 year for nurses, expiring on October 31st, 2017, and 2 years for social workers, expiring on October 31st, 2018. If you want to receive a social work continuing education certificate, you will need to complete the social work test and send it in along with your sign-in sheet and evaluation. I'm Renee Carpenter, State Social Work Director for the Alabama Department of Public Health, and with me is Kelly Lassiter, a counselor with the University of Alabama at Birmingham. Welcome and thank you for being here, Kelly.
Well, thank you for having me, Renee, and thank you so much to the Alabama Department of Public Health for inviting me to be here today to present on a topic that's extremely important to me professionally and personally. I also just want to say just a special thank you before I get started to all of the nurses, social workers, service providers who go out of your way and do everything you can to create safe and inclusive environments for all people. It's kind of ironic that we had this taping this week. We've tried to schedule several times because this is National Out Week. And so this is a really great opportunity for anyone who is wishing to show your support, to show that you're an ally, or someone who's just, kind of making the decision to come out to do so this week. So again, thank you so much for having me this week. So I'll just move ahead with our objectives and just go through this very briefly with you. First of all, we're going to define what it means to be ethical. I'm sure you have all had ethics classes before. Some of you may be new. So the definition that I provide you is one that I felt like was pretty universal to us all. So that will be the first thing that we'll do. I'm going to go over how to use culturally appropriate language when you're working with LGBTQ individuals. I think that was one of the things that came up in one of the questions that was submitted earlier as one of the most important aspects of what you were looking for in this particular workshop. Also, to be able to identify personal biases as it relates to working with LGBTQ individuals. Next, we'll talk about ways to identify, to build rapport and trust with your client or your patient. You'll also be able to identify LGBTQ resources specific to your profession. And then we'll also talk about where you can find standards codes specific to your professions that are participating in this presentation today. Would love to be able to go through all of the standards and all of the codes that are out there for each of the professions that are represented today, but it would be impossible.
Right.
We would be here for hours and hours. So first, I want to talk a little bit about some culturally appropriate and respectful language. I have narrowed this down to LGBTQ, and in this slide, I have included a second Q in questioning. There are so many different terms and so many different places you can go to learn the different terminology and things that are used that are culturally appropriate for LGBTQ populations, but I didn't really want to overwhelm us today. Right. So I'm just going to stick with what we have. Lesbian is a term that's used to describe a woman who is attracted to another woman. Gay is a term that's used to describe a person who is attracted primarily to members of the same sex. This can also be used in describing lesbians as well. Bisexual is a person who is attracted to both people of their own gender and or another gender. I'm going to talk a little bit, excuse me, I'm sorry, I went off the slide. In just a moment, I'm going to define transgender, but I'm going to skip over that for now because the definition is a little long. So I want to be able to come back to that. Queer is a term that can be kind of tricky, and it can have different meanings for really different generations. Queer is a term that we want to be careful when we're using, to use it respectfully, and only if we're allowed to do so, if that's how the individual that you're talking to or working with identifies. But here's the definition that I selected today. Queer is an umbrella term sometimes used by LGBTQ people to refer to the entire community. Some choose this term in order to avoid being boxed into a label. So some individuals don't want to be referred to as a lesbian. They feel like that boxes them into a label, or gay or bisexual. Queer offers a wide spectrum for sexual and gender expression and identity. This word, again, should be used with caution. Now, for somebody my age and my generation, queer was used really in a very hurtful and harmful manner. Our younger generation has reclaimed the word and use it with great pride. So, again, you know, if someone presents and you're not sure if they use the term queer, I would ask if it's okay and appropriate for you to do so. Questioning is the last cue, and I won't be talking about questioning much more today. I may mention it a little bit more when we start talking about youth. But this is really when someone is beginning to explore and discover their own sexual orientation, their gender identity, or gender expression. And I want to, since we're at questioning, kind of make a point to say, because sometimes it gets a little confusing, that gender identity and sexual orientation are not one and the same. Right. So sometimes when people are talking about trans issues, they may say sexual orientation, when really we're talking about gender identity. So transgender. This term has many definitions. It is frequently used as an umbrella term to refer to all people who do not identify with their assigned gender at birth, or the binary gender system. And the binary gender system is the male-female system. This includes transsexuals, cross-dressers, genderqueer, drag queens, drag kings, two-spirit people, which is a term that's used with indigenous populations and Native Americans, and others. Some transgender people feel they exist not within one of the two standard gender categories, again, which is the binary, but rather somewhere between, beyond, or outside of those two genders, the non-binary system. Now then, when we can get to the language to avoid. So I just wanted to highlight just a few terms that have been used throughout the years that you may want to avoid and be careful of using. Homosexual is a term that has been outdated for quite some time. It's another term that for many older LGBTQ people can remind of a time when in the DSM homosexuality was viewed as a disorder. So homosexual is a term that we try to avoid. So if you're talking to someone and they identify to you as LGBTQ, you may want to be careful of saying something in an effort to be kind and to get to know them of when did you first realize you were homosexual. So want to avoid phrases like that. Homosexual lifestyle is another phrase that we often hear. Being lesbian, gay, bisexual, transgender, queer is not a lifestyle. This suggests that it's a choice. It's part of who the person is. It's a part of their identity and their expression and how they feel towards another person. So again, when you're using language and talking to someone who is LGBTQ, please do your best to avoid using homosexual lifestyle. Sexual preference and homosexual lifestyle really kind of go hand in hand, if you will. So those two could be interchangeable at times. Gay agenda, I can assure you and everyone else, there is no gay agenda that's out there. We hear that a lot. Is there movement for rights? You bet. But there is no agenda to recruit or to bring about any harm or anything like that. So I hope I can put everybody's mind at rest on that. Gay marriage, we just like to use marriage. Now that it's legally recognized, marriage is marriage. And gay family, like gay marriage, it's family. So we want to make sure that, you know, if you find that you say one of these things, just correct yourself, and you don't need to go into a long apology. It happens. So the next thing I want to show you is the gender unicorn. And I'm going to give you just a little bit of information about the gender unicorn. If you have any questions, you stop and ask, okay?
Okay.
But this is really a great visual that's a little bit different. You may be familiar with the gingerbread man.
Yes.
Okay. All right. So this was developed by the Trans Student Educational Resource Center. As to show kind of the non-binary. This is not a cis male image. Cis meaning that the person's outward and sex assigned at birth lines up with what's inside and how they feel. But the gender unicorn just kind of gives us a really great image that's neither nor,
right,
if you will. So I won't go into a lot of detail on how the gender unicorn is used, but I will say this. This is a really great tool if you're having conversation with someone and they're talking to you about their gender identity or their expression, perhaps whom they're physically attracted to, emotionally attracted to. But it's, you know, for you it's something that's like, I need to know a little bit more. This is a great resource to say, hey, can we use this together? And maybe you can show me on the gender unicorn kind of what that means. So it gives you a visual representation. It was created by trans and queer people to show how they view gender instead of one straight cisgender man, as I mentioned, the gingerbread man. And it's a great resource when you're working with clients and patients who may be questioning. So someone comes in and maybe they don't know. This would offer them a resource and really send a message to them that you know, you're there with them and you're present with them and you want to explore this and talk about some of the issues that they're going through as they're questioning. It allows for freedom to self-determine where they most closely align in terms of gender identity, gender expression, physical attraction, and emotional attraction. I would, and I do, I have these in my office at UAB, but I would encourage anyone that has an office to have the gender unicorn available. You can have it that's visible, or you can have it in a file somewhere. But basically, you know, we're looking at a left to right movement in the gender identity, the top being female, woman, girl. So for a cisgender female, meaning that what we see on the outside matches up with what's on the inside, and also how we feel, would probably be pretty far to the right. Male and other gender would be very far to the left. Gender expression, that can really vary. You may have a cisgender female who identifies cisgender, but she may choose to dress and express more in a masculine sense. And I'm going to talk to you about pronouns in just a second, because I used pronouns on that. Or she could, you know, choose to be either or. It's important not to assume when someone comes in what their gender identity is. Again, I'm going to talk about pronouns in just a moment. But really just kind of go in with, you know, how they present, what they tell you their name is. The sex assigned at birth is just that, female, male, or intersex. Physical attraction, again, a lesbian may identify far to the right and less to the left or to the other. Someone who is bisexual may be in the middle of all three of those things, women, men, and other. And then emotional attraction could be, again, anywhere on that spectrum. So even for a lesbian, she may be emotionally attracted to men and women. That doesn't mean the same as sexual attraction. Okay? Questions about the gender unicorn or anything? Okay.
Clear.
Okay, great. So preferred pronouns. So if you can see, I'm wearing a button that says she, her, hers. At UAB, we're really committed to diversity, and that's diversity to all of our students. And so this is a way for me to introduce myself to someone who is maybe transgender, maybe genderqueer or questioning, and they see this and they say, oh, this person gets it. So it's important to ask pronouns. I think the pronoun that says ask me for a service provider is probably the most beneficial. The students that I've talked with and some of the younger people that I've talked with are like, you know, that really means a lot to see that, because it says, you know, you get it, you know, and so that opens up a door for conversation. These are just a few of the pronouns. There are many different preferred pronouns, and if you will go back to the resource center that I mentioned earlier, the Trans Student Educational Resource Center, and go to their website, you can Google that. It will have a list of many, many, many different pronoun choices. So one of the questions that comes up when using pronouns is how pronouns are used in a clinical setting. So again, you just ask. Another thing you can do, one thing that we do at Student Health and Wellness and in Student Counseling Services, is we actually have on our intake form a place where a person can list their pronouns. So you don't have to ask, it's already there. And it's also a good way when you say that, say, thank you for sharing your pronouns with me. My pronouns are. Do pronouns change? Yeah, they do. Sometimes they change without the person changing names. And that's okay. That's their choice. We're going to allow individuals to self-determine. And what if I make a mistake? What if I misgender? I'll be honest, I've done it. It's not comfortable. But acknowledge the mistake in pronoun and move on. Don't try to overdo it or over-explain. And one thing that I want to say that's like really important for when you're working with trans and genderqueer populations, and this is something that's been expressed to me, it's really important for us to educate ourselves and for them not to serve as our educators. Again, it's a message that you care, you're taking the time to learn about me, and these are individuals that have spent their entire life trying to explain who they are, and in a society that's not often welcoming and affirming. So now I want to move into kind of the rationale in behind this ethics presentation today. I selected a video that's through New York City Health and Hospitals Corporation. This is going to be a video that's really healthcare, in the healthcare setting, but the message that you hear from all of the people in the video is really, it's universal, it's all encompassing, and it applies to anybody that's in a helping profession. But I thought it was important that you hear stories from real people who have had real experiences. So the title of this video is To Treat Me, You Have to Know Who I Am.
To treat me, you have to know who I am. I identify as a Latina lesbian mother.
To treat me, you have to know who I am. I identify as a transgender man.
To treat me, you have to know who I am. I identify as a gay man. I was diagnosed with anal cancer, and when I'm dealing with something medical, it's extremely important that they know who I am. Every doctor I've been to, and there were 7, all of the nurses, all of the assistants, everyone treated me with respect.
It is as important to know somebody's sexual orientation, and even more than that, what their sexual scenario is, as it is to know if they're getting a good night's sleep, or if they have a good appetite, or if their bowel movements are normal. It's all part of basic bodily functions that are required for a maximum quality of life.
It's important to have an open and honest relationship with your patient. And so if you do not know what their sexual orientation is or how they identify, that patient is not going to feel safe telling you everything that they need to tell you for their proper medical care.
Knowing the patient's gender identity and sexual orientation helps a practitioner to care appropriately for that patient. We see a lot of patients come in who may not be comfortable disclosing that information, and routine testing or screening may be missed for that patient.
When I was about 15 years old, I remember going to the doctor's office, and my doctor was very warm and very welcoming. She was asking me all the questions that she's supposed to ask to an adolescent, and I remember telling her when she asked about my sexual activity if if I use condoms or anything like that, and I said no, I'm gay, and I just remember her face changed very much, and her warm tone of voice turned very harsh, and it seemed as though she was rushing me out as quickly as possible.
As a lesbian, unfortunately, when I've been involved with the healthcare system, it's usually hasn't been very welcoming. It's usually assumed that I'm heterosexual, and so the questions go along that line, asking me about the need for birth control, and then I fill out forms that ask me if I'm married, single, divorced, or widowed, and none of those boxes apply to me.
I think it's very important to know that what people write on forms does not represent necessarily their reality, and it does not take the place of a provider opening the door to ask questions.
And you need to ask those questions in an open and thoughtful and caring way.
Many times the patient or client want to talk about their sexual health, but fear that they would be discriminated against or stigmatized.
There are a lot of ways that a provider could ask me questions that would make it more likely for me to disclose the fact that I'm gay than not. So I'd rather them ask me if I am in a significant relationship, if I have a partner. And then I'd like them, when they talk about other issues, to not make an assumption that because I'm gay I don't want to talk about having kids, or that I don't want to talk about relationship issues.
My partner and I and our children were on a family vacation, and my older daughter became sick. She got stomach pains, and we had to go to the local emergency room. And we get to the hospital, and they asked who was my daughter's parents, and I said, well, she has two moms. And they were like, well, she can't have two moms, only one of you can go in. My daughter was traumatized by that. We were traumatized by that.
It's not about sensitivity, it's about respect, it's about humanitarian response to a human being in general.
My partner was hospitalized recently, very severe aortic aneurysm. When he was being moved from intensive care to a hospital bed, the nurse in charge would not let me accompany him. I asked if I would have been allowed to accompany him if I were part of his family, and she looked the other way.
What needs to happen when a patient is admitted to a hospital is that the care providers think about the fact that the patient might have different sexual orientation or different gender identity than the care provider.
Throughout my pregnancy, I was very much genderqueer, and I did tell them about my pronouns, which ones I preferred, that I preferred gender neutral or masculine pronouns. But the people who were dealing with me throughout my pregnancy, primarily my midwife and the nurses associated with them, were not responsive to my identity and didn't actually respect it. Certainly I felt that my healthcare has been impacted. I feel less genuinely listened to, and I feel like there's a huge discrepancy between the care I get versus other people who have gone to the same provider and report a very different experience.
You need to empathize with the patient you're talking to give them an understanding that you care to understand who they are. That's all you need to do. You don't have to use the right words. Just be open to being educated on what right words to use and care.
I just transitioned about 4 years ago to start living as a man. When I was diagnosed with breast cancer, I found that my breast surgeon was unable to call me, even to give me my biopsy results. He did tell me very frankly and overtly that he had problems with my transgender status, and upon meeting me and learning of my transgender status, he decided that his first impulse was to refer me to psychiatry.
I used to work at this health center that did a lot of care for transgender patients, and there was a lot of discrimination towards those patients. There was a discomfort in talking to them. I myself had some discomfort because I didn't have much training in how to work with transgender patients.
The other day, a patient came into the office, and his insurance cards identified him as Adam, although he signed the register as Emily. After being called multiple times by his birth name, he left the office.
I do think the LGBT community has special needs. I think the LGBT community has a specific special need, which is to be treated the way non-LGBT people have been treated forever, which is to be asked about their sexuality, to be asked about their quality of life, what their home situation is, what their work situation is, what their friend situation is, without the person asking the questions being afraid of what the answers might be.
Recognizing the differences of human beings and being able to address the issues and not using one ruler to measure someone else's existence or purpose in life.
My greatest hope for LGBT patients in the healthcare system is that when they go for treatment, whoever they're going to see accepts them for who they are.
And having the people that we choose to be our families be accepted, to have them be a part of the healing process.
And the healthcare system can take care of us just like anybody else so that we can keep ourselves well and get the information that we need.
To treat me, you have to know who I am. I identify as a lesbian.
To treat me, you have to know who I am. I identify as a genderqueer, biracial, Latino parent.
To treat me, you have to know who I am, and I identify as a lesbian.
Our lives depend on your capacity to care.
Very good.
I think we could probably stop this presentation here with that. So, but yeah, maybe you can see why I thought that was a really important video to show, and that really it speaks to all of us. I do want to highlight just some of the LGBTQ health disparities that maybe were mentioned in the video, but I'm going to touch on a couple of more. But first I want to answer a question. We had someone who answered a question from our audience who wanted to know what the definition of pansexual is. There's been a lot of conversation about the term pansexual this week in the news when Miley Cyrus came out and discussed her identity as a pansexual. So I just pulled a definition. It's not limited in sexual choice with regard to sex assigned at birth, gender, or gender identity. So feeling attracted emotionally, sexually to any and all genders. So there's we're not putting ourselves in a box, if you will, would be the definition of pansexual. I hope that's answered that. So here are a few more, just to kind of hit some of the highlights of the video and talk a little bit more about LGBTQ health disparities. LGBTQ youth are more likely to attempt suicide and be homeless. And according to research by Dr. Caitlin Ryan of the Family Acceptance Project, it's not due to being LGBT or Q, but rather it's because of the coming out process. If communities are not safe, or they perceive that they're not safe, they're at risk, and they're not going to come out. So if someone comes out in an unsafe community, then certainly they're at extreme risk for suicide and or homelessness. LGBTQ populations have higher rates of tobacco, alcohol, and other drug use. LGBTQ populations have a higher prevalence of certain mental health issues. Transgender populations have a higher prevalence of certain mental health issues, have attempted suicide, and are victims to violent crimes. Gay, bisexual, and other men who have sex with other men are at higher risk for HIV and other STIs. Young MSM and transgender women, especially those who are black, are at higher risk for HIV. And I would like to say that I started my work in in the counseling profession, working in HIV prevention. So my work in that field goes way back to Red Cross and working at the Health Services Center in Anniston. So I've had a lot of experience working with Alabama Department of Public Health. Lesbians and bisexual women are more likely to be overweight or obese. Lesbians are less likely to get preventative services for cancer. So I wore my breast cancer awareness pin today. So maybe for those of you who are service providers and you know someone who is maybe not accessing care because of their sexual orientation or their identity, please encourage them to do so. This is a great month, a great opportunity to have those conversations. Elderly LGBTQ individuals face additional barriers to optimal health because of isolation and a lack of cultural appropriate social service and providers. We have a lot of services for our youth and our adolescents and even our young adults, but there's really not a lot of resources out there for our aging population. And this is a population that's still very much closeted. Still remember a lot of the fear and stigma associated with that. Transgender people are at higher risk of UTIs and other urinary complications due to fear and stigma associated with use of the bathroom of their choice. So they would rather, hold their body functions throughout a day than go to a public restroom because, quite frankly, they're just afraid to do so. So what does it mean to be ethical? Ethics is a set of moral standards that is based on what is good and what is bad. It sets guidelines by which working professionals make ethical decisions for the good of the client or the patient they serve. Ethics are the philosophy behind which ethical decision is based. Now, being an ethical health professional means that you're doing the right thing effectively, efficiently, skillfully, compassionately, and competently. It's putting aside personal values and beliefs and creating an affirming and supportive space for the client and for the patient. According to each of the codes, counselors, social workers, medical professionals, and other helping professionals do not practice, condone, facilitate, engage in, or collaborate with discrimination based on sexual orientation or gender identity. And I'm going to give you some links to the NASW codes, to AMA codes, to ACA codes at the end of this presentation, so your audience can go and pull those up and read those. Several have position statements specific to working with individuals who are LGBTQ. So I just wanted to pull together some common ethical themes so that we're kind of all on the same page. Counselors, social workers, medical professionals, and the other helping professionals, the first and the most important thing, and it's the foundation of the American Counseling Association moral principles, is moral principle number 1, do no harm. Obviously, we're all in this profession to do what we can to help our clients, to help our patients, to live healthy lives, to see our students be successful, to see our children grow up, to be healthy in a healthy and accepting society. So the opposite of that, of do no harm, is, of course, to do good, which is the second principle in the American Counseling Association's ethical decision-making model. Informed consent, and again, some of these may be stuff that people already know, and you already have this knowledge. I just want to kind of reiterate.
It's a good reminder.
Yeah, reiterate that. Diversity awareness and multicultural skills. Obviously, we're doing some of that today, and that's going to be part of just continued education and really kind of self-reflection. You really want to be mindful of and stay on top of a society that's changing daily. I'm sure by the time we finish this taping, things will have changed somewhere. So again, we continue with the common ethical things. Obviously, the dignity of the person. We all want to be treated with dignity. We want to protect the integrity of our profession. We want to show that we're competent, that we use congruence, that we're real with our clients, and they see that that matches up. And not imposing our personal values. One of the things that I'll talk about just a little later on is ways that you can, you can really reflect and make sure that, you're self-aware and you're holding that mirror up and saying, okay, am I basing my decision on my own personal values? Social justice. We want to protect the integrity of the relationship with the client. We want to avoid conflicts of interest. And we want to make sure that we're using research-based treatments that are valid and not harmful. So one of the questions that came up, I'll answer a little bit later, is in regard to therapy that could be harmful for someone who is LGBTQ. Continuing education, like you're doing today. Client confidentiality. Obviously, we all want to make sure that that we're protecting our clients' information as much as possible. And serve as an advocate. I don't think a term that I've used today, and I am remiss that I did not have this in this presentation, is ally. You may hear that word a lot, but it's really important for persons who serve as allies for LGBTQ people to really get out there and be a voice. I'll be honest with you. I don't feel like we would be where we are in the LGBT community had it not been for our allies standing up with us in large numbers to say, this is not right. Everybody deserves a chance. Everybody deserves basic human rights. So allies are extremely important. Autonomy is the third moral principle in the ACA decision-making model. And this is giving the client or the patient the freedom to make choices. We talk about self-determining, and we want them to be able to have as much of their own voice in the decision as anybody else, because it's about them at the end of the day. Justice is the fourth moral principle, and that's treating the client and the patient fairly. Fidelity is the final in the American Counseling Association ethical decision-making model, and that's just being reliable, faithful, and trustworthy. And I think trustworthy, I know for myself, if I'm going to provide, I want to be able to trust that person that's in front of me. I'm not just putting my physical health or my emotional health or my family's in their hand. I'm putting a lot more in that person, so I want to be able to trust them. And then veracity is being truthful and transparent with the client and patient. I bet you want your provider to be truthful and transparent with you, right? Absolutely, absolutely. So one thing that I would like to talk about just for just a brief second is mandatory ethics versus aspirational ethics. So if you think of mandatory ethics, these are just our base ethics that we all follow. I mean, this is the bottom. This is what we've got to use in order to remain ethical. And it's really what you have to do to be able to stay out of hot water in terms of legal ramifications. Aspirational ethics takes that, and it just keeps going up and building up. It's really, hey, I've done good for my client. I'm working within the ethical code. I'm working within the law. But I know I can do more. And it really comes from internal moral beliefs about individuals and really that desire to to advocate and see change for our clients. Any questions about?
No. So that's going beyond just the foundation.
Yeah, that's going just beyond the foundation. And, you know, I think about allies that I have known in the past who work as social workers, for example, who, you know, they do their job day in and day out, and I know how tough it is going 8 to 5 and sometimes beyond, especially if you're an on-call social worker or case manager. But, you know, seeing them out at a pride event, or, you know, hearing them in conversations saying, you know what, we need to make change to our forms so it's inclusive for everybody. So, yeah, just going that step above and beyond. So now I'd like to set up a video for you. This is going to show a story of a gentleman who was featured in a documentary many years ago called Southern Comfort. And I encourage you to go and watch the full video about Mr. Robert Eads. This is probably one of the most difficult situations I've seen in terms of unethical practice. I hope that it's received in the manner in which I'm showing it. It is in no way to condemn anyone in healthcare or anything like that, but it's to kind of bring to light two things. I want to bring awareness to the importance of trans health and how vital it is to continue in their care and to build trust and make sure that our trans populations and our trans people and our genderqueer are being treated just as anyone would want to be treated. The second is to show how unethical practices can become deadly.
More than a dozen physicians refused to treat him?
More than a dozen refused to treat Robert, and he died. And it was amazing that if you go back and watch the full episode, it really just paints an extraordinary picture of Robert's life. You know, this was a man he was just living his life. He just wanted to be healthy, be with his partner, be with his son, and unfortunately he was given bad advice to not transition. I think I didn't say that in the video, and I apologize, but he was given the advice not to fully transition in his adult life, and as such, he kept his reproductive organs. More than likely, since he didn't get the preventative care, pap smears, routine checkups, it was too late by the time that it was caught. So with that, I want to turn to the ethical decision-making model, and again, this is one that's it's one of the most difficult stories that I've heard. But we want to make sure that this doesn't happen anymore. And I think because of brave people like Robert who come forward and talk about their situation and share their stories, we're seeing improvements. We're seeing more and more things like this being invited to come and present on topics that typically have been very uncomfortable for people to discuss. So let's look at this ethical decision-making framework. And there are so many out there. There are different ethical decision-making frameworks for each profession, so I would encourage you to go and look at your particular profession's ethical decision-making framework. This is one that we use in counseling, and it follows those moral principles that I was talking about a little bit earlier. So first, you've got to identify the problem, and you want to consider those moral principles when you are when you're trying to identify what the issues are. And remember, those are autonomy, non-malfeasance, beneficence, justice, and fidelity. You want to choose the one that applies and avoid choosing too many, although sometimes two or more of those will come in conflict. You've just got to make a decision of which one to address. Possible issues related to the problem, and then you want to go to your code standards and know the laws that are applicable in this situation to your state, to your profession. One of the things that I do is consult, and that was driven home to me by my supervisor and by my teachers at Jacksonville State, so that's what I do. Another thing is to consider the possible course of action, and this is a great way to brainstorm. I'd get a colleague, somebody that I trust, and say, hey, let's sit down together and see what we can come up with, and identify the one that's going to be most helpful and do the most good. You want to know what your potential outcomes or consequences could be of the decision that you're making, so certainly having that conversation. And then once you take the course of action, you want to go back and evaluate. You want to evaluate the effectiveness of what you've done. And this will require some reflection and some conversation and perhaps going back to some consult. So I would be remiss if I presented this workshop or this webinar and didn't talk about, some really good things that I've seen in my life. I feel like sometimes in these ethics presentations we tend to talk about the bad. Yeah, we leave a little wounded, and I don't want anyone to feel that way when they watch this one today. Because there's so much good. There's just so much great that's going on in social work, in nursing, in the medical field, in counseling, and all across the helping professions. But I remember very early on in my career when I started out working with the American Red Cross, it was 1996, 1997, and I had been asked to be an HIV prevention educator, and at that time I didn't really know much about HIV. I learned to think on day one when they hired me that that's going to be part of my job. I didn't realize that years later that would be so much a part of my life and who I am. But I remember a situation where an individual died from AIDS, and the family had hidden the illness and was pretty much hysterical about what do we do with their clothing, what do we do with their bedroom suit, and I was doing my very best as a very young professional to use education and all of those things. It just wasn't working at all. I was not being effective. But I called a friend of mine who's a social worker at the Alabama Department of Public Health. And she didn't do in-home care or anything like that, but I just called her to say, hey, you know, what can I do? And she said, why don't you let me take care of this? I'll be glad to go and meet with this family and talk to them. And I thought, you know, she went outside of the scope. That's aspirational ethics right there. I mean, she used the very foundation and the core of who she is as a working professional and took it to a whole nother level. And I'll remember that for as long as I live, and how great that was. So just wanted to give some shout out and some props to everybody that's doing just tremendous work. So let's talk about some special considerations. I've already hit on some for LGBTQ children and youth. So first, we know that there's higher rates of suicide, higher rates of bullying, violence, increased risk for suicide, and rejection by family in this population. There's also the increased risk for homelessness. Trans youth are at highest risk for physical and mental health related issues due to lack of adequate resources to support their care. And I just want to point out just a few things about children, because I know that a lot of people are concerned about, well, how do I talk to my child about this? Or I had an educator contact me about a very young student. They're like, we don't know what to do. He's coming to school and he wants to express himself wearing his sister's clothing, and how do we address that? And I went, well, did you go to school wearing your brother's clothing when you were younger? You know, you allow them to be expressive, and do your very best to be supportive, and in no way shame the child. It can make it so much harder and so much more difficult in later life. I know this in counseling. I hear this a lot. So we all like to explore. We all want to be 3 years old and express ourselves. So that's typically when gender identity begins, somewhere around the age of 3. The idea of sexual orientation or a crush on somebody else begins somewhere around the age of 10. Now, some people don't realize what that is, but typically that's when it starts, and that's when the questions start coming. So if you're a parent, or if you're an educator, or you work with children, I would encourage you to really, you know, educate yourself and be aware of these things. And also, this is where some self-reflection comes into play. What happens if my child comes and asks me? How would I handle that? In terms of LGBT identity in the 90s, it was 14 to 16. That's when we saw LGBT youth starting to come out. In 2005, that was 13.4. I don't have data in 2016, but I can imagine that that's going younger and younger as well. Also, the coming out process is beginning much earlier. Sorry, I've got some talking points that I wanted to stick to today. So I pulled a article from the National Institutes of Health. It was a study on measuring multiple minority stress, LGBT people of color microaggressions scale. I'll get that out in a minute. And here are some of the things that they pointed out in that particular study that puts LGBTQ persons of color at greater or higher risk. Dual minority status makes them subject to multiple incidents of racism. So I'm a person of color, so I'm already in a marginalized population. I'm also LGBTQ, so thus there's the dual minority status. Lack of inclusive services for persons of color that are LGBTQ. Our services, we really want to make sure that they're diverse and that we're treating all individuals. But, you know, quite frankly, a person of Hispanic origin may not feel comfortable going to a clinic that's predominantly white. You may have a Asian American couple that they don't want to go to a local nightclub that is affirming and supportive because it's predominantly white. Same for African American. There are higher incidents of physical and mental health related concerns with less access to both medical and mental health care. Stigma related to sexual orientation within culturally diverse populations can be even more complicated. So if you're working with diverse populations, you know, and you know that this person has come out to you as LGBTQ, you might want to talk to them about, their social acceptance, how their culture plays a role in the decisions that they're making. Increased discrimination based on partner or marital status, and concerns specific to immigration status. I knew a couple many years ago whose partner was deported because he was not a citizen of the U.S. So that's a real fear for many of our couples. And not just our couples, but for LGBTQ people in general. And increased internalized homophobia. This is kind of runs the gamut. We don't talk about internalized homophobia a lot, but LGBTQ people really have to work through a lot of the shame and the guilt that they've grown up with and the beliefs that they've developed about themselves because of their gender identity or sexual orientation. So let's talk about families just for a second. So social recognition is one of the barriers for families. Same-sex families with children, trying to navigate the child care system, schools, custody-related issues can be a problem. And again, and this is in no way to blame or in any way hurt anyone, but we do know that there are religious barriers, and that's not just with families, but that's also with LGBTQ people, again, across the board. This is a really great, I'm going to go to my allies again. So this is a really great opportunity for allies in the community to have the conversation in the church. And one of the things that I notice on the offering envelope, where it says married, single, divorced, widowed, be a great place to list an other and give someone at least an opportunity to have a choice. And a male-female other would be great as well. I think it's going to take a lot of conversation, but certainly one that would serve to benefit so many. Sadly, one of the things that I hear more often than not is that many LGBTQ youth and even adults have moved away from the church because of a lot of stigma. And a lot of barriers associated with that. Now, having said that, there are some amazing programs and some of the most caring and loving hearts out there that are, and that's who we want to go to bat for and say, hey, we want to educate and uplift and affirm one another because it's only going to make us better. Legal and financial concerns like estate planning, filing taxes. I don't know what the average is in Alabama of same-sex married couples now. But certainly there's still many more that are not married that, they're at risk if the partner dies or gets sick, that they could lose everything, including the children. Acceptance by the in-laws. We all want to be accepted by those in-laws, don't we? That's right. That's not always easy, but we do, and other extended family. Medical concerns, I mentioned, being able to make decisions. You saw in the video the gentleman who was not able to be in the ICU with his partner. He was told he was not family. And that still occurs. I've never experienced that, but I do know I have friends that unfortunately have. I think they're very isolated incidents, but certainly we can still improve on them. I did want to talk just a second, because I know we're kind of running over on our time, about domestic violence. We know that domestic violence within the LGBT community is something that is often not talked about a lot. But Domestic Violence Awareness Week is next week, October 16th through the 22nd. So you see me, well, you don't see me, I took my name tag off. But wear your purple. And again, this is just coming out of Out Week, a great way to have a conversation, right? Right. Okay. So let's talk about our seniors just a little bit. And all of this information that I'm providing you on these special considerations are from the Fenway Guide to LGBTQ Youth. I have a copy of that with me that I'll show you at the end. But they may be less likely to discuss their orientation, gender identity for fear of discrimination. Transgender patients may have complicated related to their sex assigned at birth, just in the case of Robert Eads. Cervical cancer, prostate cancer, breast cancer, etc. And then, same as with persons of color, most of the services for LGBTQ are for youth or young adults, adolescents. So there's not a lot of services out there for our aging populations. A high rate live alone. They may have children, they may not have children. but they may live alone. Partner may have died. And one thing that I want to stress to your audience is that you might hear the term family from someone that, oh, that's my family. And you might be like, oh, well, it doesn't list them as family on this intake. LGBTQ people have chosen family. So that's something to be aware of. And honor that person's wish to refer to them as family as they do. And also access to healthcare systems, retirement facilities, nursing homes could be a barrier for our aging citizens. So that's something just to be aware of. Know your laws as it relates to aging populations, as with all populations. So ways to build trust, and I know that we're kind of running over on time, and I'll go through these quickly. Take time to educate yourself. You're doing that today. There are issues that matter to LGBTQ people that I'm sure I didn't even begin to touch on today. Listen. You don't have to speak. Just listen. I guess like your mom and them told you, just listen for now. But they want to be heard. You know, their story is so important. So just take time out and be an ear. Place some affirming images around your office, a rainbow sticker, health brochures, the pronoun buttons, anything like that can, when that person walks in the room, they go, oh, this is somebody who I will be safe with. And ways to build trust, advocate for their rights. Actions really do speak louder than words. I know one thing right now that our younger generation that really kind of annoys them a little bit. No, it more than annoys them, but it's hurtful to them that people will use social media, and anytime there's a tragedy such as Orlando, people will go in and immediately change their Facebook profile to a rainbow flag, right? And they'll talk about like, oh, I support you, I've got your back, and then a week later, someone says something derogatory and they make a comment on it, then that sends a whole different message of, but you didn't support me like you said that you would. So be an advocate. Say something. If you hear someone act in an unethical manner, speak up. And you can do this without shame. And most of the time, people say things without even realizing what they said.
Exactly. It's not an intentional act.
No, they don't. People don't want to be hurtful. That's at least in my experience. People don't want to be hurt. So you may say, hey, heard you having that conversation, and here's what I learned the other day in a webinar through the Alabama Department of Public Health. Maybe that'll help you as you're working with that client or with that student or with that patient. So ways to identify biases towards LGBTQ populations. Stop and reflect. What's your primary concern? What is it that you want for your client or patient? And how might your personal judgments impact your ability to be empathetic? I think empathy is probably the most important thing.
That's true.
And it's going to show in every way. You heard the young woman in the video that went in to her healthcare provider, and she said she was asking all the right questions, but she asked her about birth control and using protection, and she outed herself as a lesbian, and the demeanor completely changed. Those personal judgments come through not just in our words, but also in our actions as well. How would you want a loved one to be treated? How would you want to be treated in the same circumstances? So now I want to move on to some questions and answers that were asked. I think most of those have been answered, or hopefully they have as part of this presentation, but I just wanted to make sure that I touched on everyone's. So the first one is it unethical for a social worker to provide treatment or referrals to other professionals or programs that are designed to change a person's sexual orientation when the LGBTQ client asks for such treatment or such a referral? Okay, so I think what this is referring to is conversion therapy. So there's just a couple of things that come to mind here when I read this. First of all, one of the things we know we're not supposed to do is practice outside of our scope. So if a client came to you requesting this and you went and did a Google search and you said, oh yeah, I can do that, I can offer that to you, that's practicing in an unethical manner well outside of your scope. Also, conversion therapy has been denounced by all of the helping professions. The American Psychological Association has a position statement, the National Association of Social Workers, the American Medical Association, the American Counseling Association, across the board, all have position statements when it comes to conversion or reparative therapy. It's very harmful, and there are several states that have actually banned it. So I hope that answers that question. Do you think it did?
I think it did.
Okay, good. Another question that has come up is how to respond to a person who is transitioning, but their name on their insurance card is different than the name they prefer to use. We have to bill based on the insurance card. Well, I think it's where you have a conversation and you're just transparent. And if the person comes in and maybe it says John Smith on the card, but they present to you and say that, you know, their name is Amy, you refer to them as Amy.
So in conversation, you refer to them as Amy.
Amy.
So billing is completely different.
Billing is different, and I would explain that to your client or to your patient, that this is the legal name that's listed that we bill from. But if that individual wants to be referred to in conversation as Amy, that in no way is going to impact billing. Or at least it's my knowledge that it would not impact billing to refer to someone by a name that they choose.
Right.
Is that correct?
That's correct.
Okay.
I'd like to take it a step further.
Sure.
About documentation. As you're documenting in a file, and you've got the name, we'll go with what you had, John Smith and Amy, documenting in that file based off the name of the billing name.
Okay, that's a really good question. So I will speak to that as a counselor and how I address that. I do have students who identify as transgender or genderqueer or gender neutral, and their name is not a name that's assigned that's in the BlazerNet at UAB, but if they tell me that their name, again, is Amy, in my case notes, I'm going to use the name that they selected and how they want to be referred to. It will in no way impact anything about the chart or any of that information. But that way I know when that student comes back how to speak to them respectfully, appropriately.
And I would think making a note that this is the legal name, but this is the preferred name.
Yes.
To me, it's no different than a legal name versus someone who uses their middle name.
Sure.
As opposed to their first name, which is the legal name.
Right. Or a nickname.
Right.
In small communities in Alabama, right, we might go to the doctor, and the doctor, walks in and says, I don't know, hey, Skip, how are you? And that's not Skip's name. Skip is, John Smith,
Sure, yeah.
if you will. So does that help answer
Certainly,
that
yeah,
question?
I think so.
Okay, thank you. That's a really great question. And if anybody else that has some thoughts on that or suggestions, please let me know. I don't know if this falls into ethical considerations of the LGBTQ population, but what is the correct term to refer to a person who fits into one of those categories? I mean, which term does each prefer so as to not put the person on the defensive? I think you ask. Which one that they prefer. They'll let you know if you're not sure. If a person is transitioning from male to female or vice versa, but have not fully transitioned and still legally are the sex they were assigned at birth, but want to be called by the name they will be called once they fully transition, how do we handle that? I think maybe that's similar to that same question.
To the documentation question.
To the documentation, yes, to that question, is refer to them in conversation by the name they choose to be referred to. And in the spirit of transparency, I would probably, and I've done this, bring the client or the patient in and have the conversation with them about how this is going to be documented and why it will be that way. But that you will certainly use the name of their choice. So I hope that helps. That's something that I do that I have found to be effective, and it actually builds rapport.
I think it would be very affirming.
Oh, yeah, it really is. Gender dysphoria, what that is and the issues surrounding it. So gender dysphoria used to be known as gender identity disorder in DSM-4. DSM-5 has changed it to gender dysphoria so as to not label or categorize this as a disordered condition, if you will. I'm not going to go through the criteria for DSM-5, but I would encourage anyone that's out there. The American Psychiatric Publishing has a really great 2-page handout on gender dysphoria and why the changes were made. So I think this could probably give greater detail and insight into, and it'll actually give you the criteria that the DSM-5 uses. Gender dysphoria is a diagnostic criteria that's used for individuals who are going through gender-confirming therapy. If they're beginning the stage of counseling, to be able to have that to support their transition, whatever that transition looks like to them. I hope that answers that question. But again, these are things we could spend all day on. I would encourage you to contact somebody at University of Alabama at Birmingham. We have a great sexual health clinic in our department that you could call to ask many questions. Also, you could call our counseling office. One of my colleagues is a gender identity specialist, if you will, and so that's what he does. He works with a lot of our students who are coming in who are seeking consultation or actual transgender transition services. So you could call us, and you'll have my phone number in just a minute.
Okay.
Cultural competency, I think we're doing that today. We've covered that. Barriers, issues these populations have to deal with psychologically and psychosocially. I hope I've covered that information in this particular presentation. So that's some of the questions that I received. I did want to list for everyone that's there for just a few minutes where you can find the standards, codes, position statements for working with LGBTQ populations as it relates to your profession. And I selected the ones that I knew that would be participating today.
Right.
Now, I know that these won't stay open. If you're trying to write that down right now, it's going to go away here in just a second.
They can print these off.
Oh, can they? Okay, well, great. Well, that's wonderful. I was going to say you can email me, and I would gladly send those to you and my mound of notes that I have right here. So some additional resources. The Association for Lesbian, Gay, Bisexual, Transgender Issues in Counseling, or ALGBTQ, it's a funny little name, is the Alabama Association division for the Alabama Counseling Association. This website is a one-stop shop for all things LGBTQ, ethics, legal concerns, medical providers, just basic 101 information. So go to that website, check it out, it's really great. You see the other resources that are listed there for some of the other populations that were covered today. Here is my information. Please feel free to contact me. And just in closing, I just want to say a couple of things. First, know your laws in your state regarding LGBTQ service and in working with LGBTQ people. A great place to start is with the Southern Poverty Law Center, the SPLC. You can go on Google, and I'm in no way promoting Google today. I know I've used them a few times, but I promise you I'm not getting paid by Google services. But certainly they have a really great website with a lot of information, and they have some folks that'll come out and actually speak to your group and provide just kind of the legal side of it. Remember, you don't have to be an expert to care. None of us have to be experts to care. This information today hopefully is a starting point for you to get to that place that you want to be as a caring professional. And I just want to kind of reiterate what I said in the beginning, and thank you all so much for everything that you do for everybody, just to help people and make people's lives better so everyone can be successful. And I mean this, and people that know me, if there's anybody out there watching it that knows me, what you're doing is truly changing and saving lives. I've seen it firsthand, and I can't thank you enough for being there when people need you. They need you the most. So thank you, Renee.
Well, thank you, Kelly, and I appreciate you coming and sharing all of that with us today. And I want to thank our viewers also, and we will see you next time on the Alabama Public Health Training Network.